Lovely. Good morning, everyone, and thank you so much for joining this really interesting and really important session on housing and mental health. My name's Claire Murdoch. I'm the National Director for Mental Health for NHS England, and I'm also, to my great shock and horror, I realise I've been a registered mental health nurse now for 40 years, and I just don't know where those last 4 decades have gone. And I'm also the Chief Executive of an NHS Trust, Central and North West London NHS Foundation Trust. So, yeah. Mental health, as you will have gathered, is hugely important to me and a big part of who I am and my interests over decades. The ICBs, our integrated care boards and systems, are such an opportunity for health and care to work more closely together. I know in parts of the country for a long time now there have been some great relationships, and even throughout the austerity, which if I think back really began in 2008, 2009, and we thought it would be over by 2015 at the latest. How wrong we were. But even throughout austerity and during some really tough times, there are already great examples of whereby working in partnership, allowing innovation, being creative around the needs of citizens and service users, we're doing some amazing things. So I'm very excited that we'll soon be hearing from David Thorpe excuse me, from the West Yorkshire ICS system, and we've got the North Eastern Cumbria system, and Tees Eskin Weir and Rachel Byrne and Alexandra Guy. They will talk to you about some of that great work they're doing. The ICSs, however, I believe if they're to fulfil their real potential over the next 10 years, but starting now, really will have eyes on people in their population living with great complexity, maybe lots of co-occurring conditions, multiple stigmas, discrimination and inequalities. And it seems to me that whilst people with mental illness or mental health problems are not the only population that might fit those characteristics and criteria, they absolutely stand out as a group of people who need all of our best attention and partnership. I think, I hope you do too, that housing really is a fundamental human right. And if I look at, England in 2023, to be honest, I'm appalled at how hard it can be sometimes to get housing, the right kind of housing, often supported housing for people with mental health problems or mental illness. I asked for a quick trawl of our delayed discharges. Just the current status today, and we've got about 34% in some areas of delayed discharges. Sorry, 20%, but 34% of those are people waiting for housing. And I know it's very simplistically put, but I think we do all need somewhere to live, someone to love and something to do, but very much starting with the somewhere to live. My big worry as the sort of NHS chief for mental health in England is that by default, if we don't have housing for people and the community packages of support that they need, they will stay longer in mental health hospitals, often detained under the Act because they're too vulnerable to just discharge to nothing, or we put people into bed and breakfast. I think London have calculated as one region that they alone spend about 25 million a year on B&B, where people might go for a few days or a few weeks, and imagine if they have a family and youngsters as well. So I do think it's a human rights issue. I do think that by default, if we don't make housing work, we will end up incarcerating and detaining people for weeks, months, and in some cases years longer than we should. And that's simply not the policy that we have as in this country, and it's simply not how a civilized society or health system behaves. So our partners are and I'm going to hand over to Ewan and others, there are people that live and breathe housing and supported housing and creative solutions to some of the challenges and undoubted pressures that are real. And I, for one, am really excited to be co-chairing this event today with Ewan. And I'm going to hand over to you, Ewan, for you to introduce yourself.
Thanks a lot, Claire. Hi there, I'm Ewan King. I'm the Chief Executive of an organisation called Shared Lives Plus, and we support the improvement and growth of shared lives. And I'll tell you a little bit more about that shortly. I'd quite like to come at this discussion today from a personal perspective. I first thought about housing and mental health when I was probably 20 years old. My brother was actually sectioned and was in hospital for about 8 months. And he was in these old Victorian wards, lots of rotation of nurses and doctors. He didn't really get to know anyone. He was surrounded by pretty unwell people. And he didn't want to go home because home was where a lot of the triggers were for how he had got so ill. And there just wasn't any options. I remember thinking there was nowhere for him to go and live somewhere that he could get a bit of support and recover. I think things have improved, not as much as we'd want them to, but we have now got much more of what we now call supported living, which is effectively a wraparound form of housing with care that gives people somewhere safe to recover and then move back into independent life. And I think someone like my brother would have definitely benefited from that kind of option in the past. I mean, one of the other options that's out there that I'd love to touch upon, because it's part of my role, is Shared Lives, which is a housing with care option, but it's slightly different. A Shared Lives arrangement involves an approved carer, carefully selected and approved carer, who is then matched, and that's the beauty of it, with someone who needs support. And that person could have learning disabilities, that person could have autism, could have mental health. And the other beautiful part of it is that person who's, once they're matched, that person who needs support then comes and actually lives with the carer, lives in the family, lives in the community, and that by being in that loving household actually can make a really good recovery from mental ill health. And just an example, and I'm sure Claire, I know actually at North Central London are looking at this at the moment with Camden and Islington, but in South London we're helping South London and Moseley NHS Trust, or SLAM, slightly inappropriately called, but Mental Health Trust is looking at how they can develop shared lives for mental health in Southwark. And I think what's really interesting for today's discussion is this has come out of a partnership discussion, the Southwark partnership with the council, with the trust, with the voluntary sector, saying, look, actually, this could be a really interesting solution. Let's get together, let's design this together, let's involve people with lived experience and come up with something quite exciting. So they're going to set up a step down shared life service for people with mental ill health. And the reason they're doing that, and Claire will know this, is that there are many people in South London waiting over 60 days for somewhere to be moved to and somewhere safe to live. They're often ending up in bed and breakfast. Sometimes in the worst cases, they're ending up homeless. We need to find more creative ways to create options like shared lives and extra care. And Jeremy, who's here later, will tell you about many of the other innovations out there that I think are really important. I mean, just finally, I was quite pleased when I read in the adult social care white paper, putting people at the heart of care, this emphasis on every decision about social care being about housing. And then that paper goes on to talk about specialist housing, the importance of strategic partnerships locally. I think ICB's come into that space, and I know that Neil, who's on the call as well, Neil, there's some really good stuff going up in the northeast of England on bringing that together. So we'll hear some of those examples today. And I will probably stop talking now because we need to move on, but that's just a little bit of a personal introduction. I'm going to hand over, if it's okay, to David Thorpe, who's going to take us into the first session about what they're doing in the West Yorkshire ICB area. So hopefully this hands over to David.
Thank you, Ewan. Hopefully it does. Good morning, everyone. So, as Ewan says, my name is David Thorpe and I'm Care and Health Manager at WDH. So we're a registered provider, and I'm going to take you through our journey of how we support local people living in Wakefield and supporting them with their mental health. Next slide, please. So just a bit about us. I won't touch too much on this because obviously the slides will be produced afterwards, but we are a registered provider of housing. We were part of the local authority, but we transferred in 2005, and we've got about 1,350 employees, and we own best part of 32,000 properties now. Next slide, please. We are predominantly based in Wakefield, but as our areas of operation have expanded and we've taken on new homes, we have expanded our portfolio, and these are some of the areas that we're now covering into providing housing and housing related services. Next slide, please. So our journey with health really started, I suppose, when we transferred from the local authority. So back in 2005, we had the 2012 Decent Homes Agenda, and we wanted to go beyond that in Wakefield. So as we started engaging with as customers, we started engaging consultation-wise in terms of some of the components we were going to look to improve. We've really got to know and understand our customers from a health and a lifestyle perspective, some of the living conditions and standards, etc. Our vision was created in WDH to create confident communities. So to do that, really, we need tenancy sustainment and sustainability. So the idea for us to work from a proactive rather than reactive estate management, traditional housing management function, what the emphasis really, and that's when we decided to put services and support services in place and invest in our customer base. Next slide, please. So thankfully for me, it gives me a job. As you said, I'm Care and Health Manager at WDH, and I'm responsible as Head of Service for a suite of services. Most pertinent to this conversation this morning in terms of supporting mental health, I'll take you through those services. But our, like I said, vision is to create confident communities, and we do that by supporting our tenants to maintain successful tenancies and healthy lives. And it's really important that we address the wider determinants of health, and housing is seen as a key determinant to physical and mental health. So it's about making we've got the best support in place to support our tenants in our communities, reduce those inequalities to enable them to live fulfilling and healthy lives. And for us as an overall ambition as an organisation, we obviously get high levels of tenancy sustainment, and tenants feeling supported to manage their tenancy successfully. Next slide, please. So in terms of integrated care systems, the job for me in Wakefield is to kind of align our strategic objectives with that of integrated care systems. And you'll see here 4 key strategic objectives of an ICS, so improving outcomes in population health and care, preventing ill health and tackling health inequalities in outcomes and experience, enhancing productivity from value for money, and supporting broader economic and social development. So you may ask, how do we improve outcomes in population health? Well, if we get the home right and we get the support and the wraparound support right for that customer, then we can actually sustain that tenancy and give them better opportunities within that locality, in that community. So can we improve outcomes in population health? If we press on, it should give us a tick. We can. Prevent ill health and tackle inequalities. If we address that at the earliest opportunity by working with as estate management colleagues from a housing perspective, we can address those health inequalities. Enhance productivity and value for money. I'm going to show you a bit later on how our offer and our supports not just health partners, but also for us as a landlord and a registered provider. So yes, it can support that. And finally, supporting the broader economic and social development, how we can look to inform and shape and influence to the development of new properties, new homes, and contribute again to the ICS. Next slide, please. So how does housing help? Unfortunately, some of the people that we see might be living in conditions like this. So it's up to us to try and address that issue, and making sure that that person lives in a safe and healthy home as possible. And on to the next slide, please. We do it by addressing health inequalities. So back in 2012, following the Lansley reforms, we worked with primary care trusts as there was then. We looked to address it by having health inequality workers. And the work so much so for us in Wakefield give us real traction, and it really transformed the way that our customers felt. So we weren't just coming from a reactive lens, addressing antisocial behaviour or arrears. We've got to the real heart and the cause of those problems by addressing that health inequality. And so much so that the work that we saw in Wakefield was fantastic, and that we brought them mainstream in-house, and we created the Wellbeing caseworker role. And then had that piece of work evaluated. Oh, back a slide, please. Back a slide. I then had that piece of work evaluated by Bradford University, and the work that they did identified that, yeah, we were doing a fantastic job to address health inequalities, but we had a gap with addressing low to moderate mental health amongst our tenancy base. So working with the local mental health trust, we were able to put a concept together, and from a housing provider perspective, we would 50-50 fund 3 mental health navigators that would work and be seconded to the housing team to address low to moderate mental health issues amongst our customer base. As I said, we've got best part of 32,000 properties, so quick maths, 1 in 4 is supposedly to have a mental health condition. So for us in Wakefield, we had 7,500 potential problems behind our doors. So we're about how we would engage with those customers. So for us, obviously, we're addressing the low to moderate mental health issues. We're getting that tenancy sustainment, but it's being delivered by clinicians who can give the coping mechanisms and strategies. But ultimately for health, the people that we are renting our accommodation, they aren't having to escalate into crisis GP or go through A&E services. And I think that's really, really important, really, in terms of helping people to live well and age well, but also to give them that element of independence as well. Next slide, please. So as those partnerships and collaborations grew and we got to know each other, and the trustworthy of the relationship between the commissioners and the providers and us in housing, we were able to understand what they needed from us, but also they understood what we could do. So obviously we had in housing mental health clinicians, and then the mental health trust would talk about barriers to discharge and people bed blocking, so they're medically optimised, fit for discharge, but there's nowhere to go. And that's where we were able to reciprocate that arrangement and build on those partnerships that we had, and we put a housing professional back into that space in terms of improving patient flow, addressing NHS priority ambitions. So our housing coordinators would then be a housing professional that would integrate with the transfer of care team, including the local authority and the healthcare professionals. But it would ultimately make that transition pretty much seamless. So there would be profiled at the earliest point of opportunity, point of admission, and we get as far upstream as possible. So they are profiled and put on housing registers, etc. And then, like I say, when they are fit to come out, they can actually go out. And that made a massive, massive difference, really, and really furthered and cemented that partnership that we have with health. Next slide, please. I'm then fortunate enough to get some money to support the housing coordination function, have that evaluated from academics from Sheffield University. And this is really then when we went from Wakefield Place level into the West Yorkshire footprint and showcase what we'd done at Wakefield and the power of the housing coordination function. I worked with the DWP. In the bottom corner I've circulated some of the outcomes and findings were challenges around people who were presenting in the hospital who were homeless, but also there was an opportunity to work with people who had mental health, learning disability and or autism. So we're able to work up a proposal then from what happened locally in Wakefield hospitals into the West Yorkshire footprint. And again, that were really, really great in terms of taking that to the next step, really, and showing West Yorkshire the power of that service and commission. And that's where we're at now. Next slide, please. And then I've put this in terms of a governance slide. So as my role as care and health manager at WDH, I have a number of strategic responsibilities working with our healthcare partnerships. So I've circled these for you here. So I am the chair of the Housing and Health Social Care Partnership, one of the programming alliances, and I also sit on the Mental Health Alliance. Some of the key work streams that are coming that way, obviously our customers, our tenants will be using those services. So it's really in my vested interest I get an understanding of what some of the mental health strategic ambitions are and some of the local authority partners and the voluntary third sectors, etc., and how we can align those. And then also sit on the Transformation and Delivery Collaborative, which is where all the key alliances and programmes that work that goes up into that forum in Wakefield, so we can determine key work streams. And then in the top right hand corner, you'll see the West Yorkshire Integrated Care Partnership. And as my role, I am now the programme manager for the Housing and Health Programme, which sits as part of West Yorkshire's Improving Population Programme. So because we've got that locality presence, we can then shape and influence at system level, and I think that's really, really powerful what we've got in Wakefield and West Yorkshire, and how housing is really, really integrated in terms of all the governance, really, that we have got a place around that table, and we are seen as a key enabler to providing health and housing. Next slide, please. And again, I've just put this in just for a bit of feedback, really, in some of the outcomes that we get by having those relationships in place and supporting mental health. We're able to work closely with, obviously, the person who we're going to be providing support for. Unfortunately, in this case, the person passed away not long after we were discharged from hospital. But I think some of the comments that we realised were really fantastic and testament to the power of that commission and the power of that service. And it is really something that we're very proud of. And some of these like person-centred outcomes are really powerful. And this is some of the softer side of things. It's not just about the finance and making sure that it's the right thing to do from health and housing perspective. It really puts the customer and that person at the heart of the decisions, and you can see some of the great work that they've done there. Next slide, please. And then I put this in because sometimes for a housing provider, it's not a statutory duty for us to do what we do in providing mental health support and wraparound support, but it does make good business sense for us as well. And by having those support services in place, you'll see our stock portfolio, best part of 30,000 at the time this was taken from our arrears benchmarking. But you'll see other providers with a similar sort of stock portfolio, yet their arrears as a percentage of debit from their rent collection rent roll. It's just unfortunately not as good. So I think that's really testament to the model that we have in Wakefield and ultimately within that West Yorkshire footprint. Next slide, please. So I think for us, for next steps, the WHO's report, all around the housing coordination function, it's about the dissemination of that and making sure that we can help and shape and influence in terms of commissions and building on that. Obviously, unfortunately, with the our Bishak situation and the new reforms that will come there, we can look at damp, mould and condensation, having housing coordination function to support people living in conditions that would potentially exacerbate asthma or other conditions. We've got the housing coordination, learning disability and autism in place, and that is at regional level now at West Yorkshire. So that's getting embedded, and ultimately we'll get some really good learning from there. As I say, I'm the Housing and Health Programme Lead for West Yorkshire ICS now, so working with improving population health. We can have conversations across the improving population health workstream partners. So we've got addressing health inequalities, the suicide prevention and other key programmes, but housing is a key part of that, and by sitting there and listening to other housing providers throughout the West Yorkshire region, I'm able to try and align all those different objectives and bring us together a collective programme for next year. It builds on that partnership and collaboration, and ultimately for us, by having housing in those discussions, it's a win-win for everyone concerned. So I think that's it, ladies and gents, from me and from Wakefield.
Thank you, David. That was really informative and a really good example of partnership working in Yorkshire. So we do have time, by the way, later for questions and answers. So do keep them coming in. Those questions we are going to ask David and Rachel and Alex to answer some of those questions in a bit. But I'm just going to move us straight on, if that's okay.
Thank you.
No worries. Move us straight on to hear from Rachel and Alex. We're going to talk about joint working, particularly around the delayed transfers or the discharge pathway from hospital, and that's in the North East and North Cumbria integrated care system. So I'll hand over right now and let them tell you about that.
Thank you. Hi. Yes, I'm Rachel Byrne. I work for Home Group, creating new models of care. I'm Exec Director of New Models of Care. So I'm going to do a brief introduction. I've got a great colleague with me called Alex, who has done a lot of work in this area. So we are a national organisation. About 6 years ago, we took a decision to support health in different ways that we could, and started to interact with lots of different trusts. And now the ICSs as well. Our raison d'etre is to work with the most vulnerable in society. That's our social purpose that the Housing Association has. So how better to do that by actually engaging with health and helping on, particularly on the discharge type services. We've now got numerous different step down services across the country with different trusts, but we're going to focus today on T's. And we also do a number of housing projects. So lots of housing associations are in this position. They will have properties that they haven't been able to use for some time, and with a bit of negotiation and a bit of luck, we have managed to convert some of those so that we can actually take longer term customers straight from hospital into our schemes. So we do a whole range of things. And the only other thing I'd add that has massively helped us is we have put in a clinical infrastructure into home group. That's quite unusual in housing. There are a couple of others who do it as well, and that has a fantastic impact. We have about 40 mental health nurses across our supported housing, and then we have specific specialisms, OTs, mental health therapists, and more that I can't remember today. So I think we have about 70 colleagues across all of that, and that enables us to do more of the work that we want to do. So I'm now going to shut up and hand over to Alex, who'll tell you about our service.
Oh, fantastic. Thank you, Rachel. So yeah, I'm just here to introduce our hospital discharge service today. So yeah, as Rachel mentioned, we've got a few of these services kind of up and down the country that are absolutely thriving, but just this is a bit of a focus on our Tees service today. So effectively, the model involves home group support coordinators working on wards alongside clinical teams. So when a patient is referred into hospital and they're identified as having a housing need or a social need, particularly something that might go on to be a barrier to discharge, they then get referred to the home group team, who meet that patient, carry out an assessment, and kind of work collaboratively with them to try and find solutions. Early intervention is really important, so getting involved from the point of admission or from the point at which it becomes medically appropriate is really important for us and helps us find the right solution for that customer. And the primary aim of the service is just to make sure that people have access to safe, secure and appropriate housing when they're ready for discharge. But the team also get involved with things like making sure people have got the right benefits, they can manage their bills, they can manage their finances, and they've got the independent living skills that they need to thrive outside of that ward environment. So the team follow the customer into the community and provide a little bit of outreach support as well, just to ensure that they can sustain that independent living and that they don't come straight back onto the ward. And the reason that we kind of do this really well is because it plays to our strengths. So as a housing provider, obviously, we're really embedded in those local systems. We've got lots of knowledge about local housing policies and processes, but we're also really experienced in dealing with the benefit system as well. And that means that we can work, be a little bit more creative and find solutions that sometimes other organisations couldn't. And that often means that we can support those most complex customers as well. So those individuals who might be described as hard to house, people with a history of arrears, people with a history of arson, or people with dual diagnosis as well. So yeah, it's just about letting us play to our strengths, letting us do what we do best as housing specialists, and freeing up clinical time. So since we started delivering the model, it has evolved a little bit. So initially it was focused primarily on mental health wards. But obviously we're not providing any mental health support. So it's grown massively now, and now we have services on our acute wards, and we're also in a few areas working with crisis teams, psychiatric liaison teams and community treatment teams to provide the same support but in the community with a more preventative approach. Next slide, please. Thanks. Yeah, so we did a little bit of a study across 6 of our hospital discharge services in the North East. We had to remove some individuals from the study who were outliers, who'd been on the ward for over 200 days. But even with removing those individuals, our service reduced the average ward stay by 70 days per customer. So obviously that's a massive cost saving for the hospitals, but obviously there's a knock-on benefit for clinicians, for the customers who are being supported by the services, but also for the individuals who would be waiting for those beds as well. So it really is wide-ranging in terms of impact. If we could go on to the next slide, please. Thanks. So yeah, in terms of outcomes, obviously, impact on the people who are working a lot alongside those home group workers has been absolutely huge. So 60% of clinical staff have said that the home group service has had a positive impact on them, and 70% of clinical staff have said the home group service has had a positive impact on their team. 50% of staff feel more positive about their role since home group started working with the trust, and all of those impacts are due to better clinicians feeling better able to manage their time, clinicians being able to get more face-to-face time with patients, but also better collaborative working across the whole system. And what's been really interesting for me is that even on wards where there was an existing discharge service, that housing expertise, because it is so complex and it is quite niche, we've still been able to add a massive amount of value to those teams and support that more complex customer group, whereas other organisations maybe couldn't. If you could go on to the next slide, please. Sorry, next slide. Thank you. Yeah. But yeah, obviously, the main impact has been on the customer. So I just wanted to leave you with a customer story, if that's okay. So this is Sean, and Sean was supported by our T's hospital discharge service. He's a 65-year-old gentleman, and he's got some quite long-standing mental health issues, and was admitted to hospital in July 2012 under a Section 3. Over a period of 10 years, there were numerous attempts to discharge Sean, and unfortunately, none of those attempts were successful. So obviously, he was still on the ward 10 years later when the home group service was set up. So he was referred to us in April 2022 with barriers mainly relating to housing and his financial situation as well, but also his confidence. So obviously, having lived on a ward for 10 years had really affected his perception of his ability to cope. So we did a lot of work with him around building trust and around getting him ready to leave hospital. So our team sourced Sean a property in an area that he knew and an area that he felt comfortable in, and we kind of really gave him ownership over that process. So he's selected the property, kind of chose his own furniture, really felt like it was his home. And then 3 months after being referred to the home group service, he was discharged on the 25th of July 2022, and I'm pleased to say he's still absolutely thriving. So he's had no ward readmissions since discharge. He does have a little bit of outreach support in the community, but he's living as independently as possible, and has even just got himself a dog, which for many people who thought he'd be on that ward forever, is just absolutely huge. So yeah, the financial savings are obvious, but yeah, for customers like Sean, it has an absolutely immeasurable difference. And yeah, just wanted to share that with you today.
And he too wanted to share it, didn't he?
He did.
He wanted you to share his story.
Yeah, absolutely.
Thank you very much, both of you. That's really a wonderful way to end a presentation with the story of Sean. Lovely to hear. So we do have a little bit of time for questions before we move into the panel session. Just one quick one from me. I noticed in both of your presentations the importance of having a housing expert or housing specialist based on the wards. Why don't we do that everywhere? And what were the barriers to getting to that place? I'd really like to know. Anyone like to pick up on that question? David, how did you get the housing people actually onto the wards? Because I can't imagine there must have been some discussions to make that possible.
Shall I say something quick? Oh,
yes,
there,
please.
Yes,
please, yeah.
I'll say one bit because it's only quick.
Yeah,
it's
please.
Basically about us going to the NHS and offering them some services rather than, I think, yeah, but it's never going to quite happen the other way around. It'd be good if it did, that health were able to sort of request it in a way. But for us, it was about, we need to get on the wards and we need to talk to health ourselves and then work out how that partnership works. And we can do it in areas where we've got big concentrations, but it's not so easy where we don't have a concentration of stock or colleagues.
Thank you. So another question that's come from the audience is probably unsurprising given the mention already of austerity and the impact of that. So how in difficult times are you managing to increase the supply and options of housing? Is there any creative ways that you've been able to do that, because there's so many cuts to different parts of social care at the moment? Any kind of creative ways of building more houses and more options?
Less options for building single houses, but what we have done is So the way in which we do developments, obviously we get grant from the government to do that, and we've had a number of schemes where there is a lot of grant tied into them but have been empty. And so we're bringing those back into use, working with the local authority and with health in an area to be able to redesign that building and modify it so that we can then use it for a discharge service. But I suppose it is an advantage as a housing association. We won't be the only ones that have got properties that have became not suitable for the current group, but have all this grant in them, so we can't sell them. So we might as well. It's a good option to transfer them into services like this. I'm not saying there's hundreds of them, but there are a number of them. That's what we've used mostly.
Thank you. And if David, anything from your perspective? Doesn't have to be.
Obviously, as a registered provider, we have an investment strategy, so we try and put as much new pipeline in as we can. We try and deliver 400 or 500 units a year, and then obviously working closely with local authority strategic housing colleagues, try and make those informed pathways really into shaping and what they're about as well, in terms of creating new stock and different types of supported housing or accommodation to meet the needs of the customer demographic, really.
Thank you, that's really helpful. Another question here. How do you ensure that the service is equitable across different faiths, cultures and ethnicities?
I can speak to that a little bit. Yeah, so I think for us, it's all about kind of really already being embedded in that place, embedded in those communities. So whenever we do kind of start setting up a service like this, we work really closely with our recruitment colleagues, kind of do an analysis of the recruitment market in the area, look at groups who might be accessing the service, but where individuals from those backgrounds might not apply for those roles, and we'll kind of go and directly do some outreach with those communities to try and get the right people working in the service who understand those needs and can make the service really responsive.
Thank you. If any other thoughts on equity issues and how you ensure that through your housing and mental health approaches? Okay, well, I'll move on. No, that's fine. I'll move on to another question. No, these are tricky questions, to be honest. So one person was really amazed by the work you're doing with the home group and also in Wakefield. What would your tip be for any mental health trust to bring local housing providers to the same partnership arrangements as you have? How do you bring people around the table to make these decisions jointly?
Alex, what do you want to say about what's happening with you?
Do go ahead, Alex. Thank you.
Yeah, I think for us it's about trying to be really creative in the opportunities that we kind of look for to work with the trust. So obviously, there's some areas where we do have existing relationships, but other areas where we just don't, and often it's just a case of kind of a cold calling or sending emails to various departments and just hoping you get the right person. So I think for us, if trust were able to kind of reach out and just kind of provide those contacts or provide forums like this even are really useful. Something going on in Greater Manchester at the moment is they're doing kind of a secondment programme that I'm involved in with individuals from across the health and care system, kind of working on a research project 1 day a week with the trust, and it's all about kind of facilitating that exchange of knowledge, which is really useful. So yeah, I think it's just about being creative, but also kind of being really open about it and kind of putting it out there. And there's countless housing providers up and down the country, and I think if you do put something out there, you absolutely will get a response. Thank you.
Another person has asked a question about stigma. They've and the persistence of the stigma around mental ill health. And I imagine that just comes up as an issue in all of the services. It comes up in shared lives. It makes it sometimes more difficult to recruit carers. We find the best way is to have people with mental health who live in our services come and speak to audiences and talk about what they experience and how things improve for them, and it really kind of opens up their lives to other people, and the stigma kind of melts away a bit, to be honest. What is there anything you have to do work on in terms of stigma around mental health? Any reflections? Doesn't have to be, but
I suppose one of the things, when I was saying before about how we've recruited a clinical infrastructure, the majority of them are mental health practice leads. So it doesn't quite answer your question, but it does mean that we have leads in all areas who work with both our colleagues and our customers around mental health. Do we reach out enough? Possibly, but maybe not as much as we could externally, and that's why we've kind of created our own infrastructure, so that we feel safe and that our customers feel safe and so on. But yeah, we probably have less from the external sector who bring us stuff.
Thank you very much. So there's just another question for home group here, or both, actually, both organizations. So do you cater for other customers, other people who don't use your housing services, or is it focused exclusively on people who are already tenants? Does that make sense?
Oh, it does make sense. We probably do more of the other than we do of people in our houses. Yeah, we do lots of kind of outreach work and the hospital work and discharge. So I suppose it's our communities, basically. We also, obviously, people do live with us not on the supported or the care side, but in our housing stock. But we also, at times will reach out to them about certain things. That might be about mental health, it might be about other health issues. So I suppose it's our raison d'etre. That's what we are. We are a housing provider, but we are housing, care and support. So we try and make sure that the access for that is across the piece.
Yeah, ours is the same, Ewan. So the mental health navigator service is predominantly for WDH customers, but that is aligned to the community mental health offer. So there is parity irrespective of tenure where you live in Wakefield. You can get access to a mental health navigator that'll deal with low to moderate mental health conditions, and then it also allows access into secondary services. And then with our housing coordination function, it's just patient led, so it doesn't matter where they live, where they're from, whether they're a WDH customer or not. It's irrespective. Yeah.
Thank you very much. Just final, I think we've just got just enough time to squeeze one more question in, which is again about resources, and I think this will come up again and again later in the discussion. So you got mainstream housing associations. We do know that some of them have resources to bring to bear, really, and how do we encourage them to add to the pot, really, because money is really tight and it can't come always from the local authority or the NHS. Any other suggestions on that?
Yeah,
go on. No, go on. Yeah, right.
Sorry. Oh, thank you. Yeah, I think for us, one of the things that we've kind of been able to do is really look at the data we're collecting. So kind of really demonstrated every service that we've got up and running, doing like a cost benefit analysis, and kind of ensuring that we're creating the right outcomes that NHS need to kind of go back to the ICBs and say, look, this service works, and kind of really justify that funding. So I think being really creative with the data that we collect, but also kind of being realistic about it. And sometimes conversations do start, and then something changes in the trust, and the funding is lost. And I think as a sector we need to kind of be ready to just kind of pick up those conversations and run with them, as and when new funding pots do kind of open and close.
Thank you very much. Right, I'm a little bit over time, and so I'm now going to hand back to Claire, who is going to take you into the panel discussion.
Thank you so much, Ewan. I'm completely in love with you all. Just listening to you talk about your work, the absolute human being at the centre of what you do and how you think about, plan for, understand the technicalities, big business head, big heart, big values, and just practical application came shining through there. And wow, just wow. And certainly as I go into chairing the panel discussion, I definitely want to ask both ICB colleagues and health, well, what's your big ask of housing providers, and what can you give ICBs? What's the give get? And I want to ask the housing providers and supported the people on the panel the same question, really, because part of what I felt listening to all of that was sometimes these parallel universes of hospital and home connect, and colleagues who've spoken are the bridge and they bring it to life. And sometimes I got the feeling that we sit with these parallel universes with nobody quite knowing how to build that bridge across, and whether it's people just too busy in health to look up and sort of think about who can help them solve a problem that they're feeling as theirs, or worry that it'll cost money they haven't got, or I don't know, but it's a strange old thing. I'm very interested to hear from people about, well, how are we connecting this bridge and making things happen? And I'm going to put another couple of things out there before I open up to the panel to sort of stimulate the thinking and discussion, because we have out of area patients in the acute inpatient area and locked rehab and so on and so forth, and we spend as health hundreds of millions of pounds every year on that care, where, to be honest, we send people 100, 200 and 300 miles away from their home because we haven't developed locally the flow, sorry to get a bit NHS-y, but you know, the ability to admit everybody we need to admit, care for people in hospital, and then discharge them as quickly as you can when it's appropriate, so they can get on with life that's not medicalised. And so how great would it be if we were spending those hundreds of millions of pounds on care locally and on more housing and supported housing, so that our illest people or those in greatest crisis can get a bed locally when they need it, that admissions can be short, purposeful and therapeutic, and we've increased the flow out of hospital for people who need it, instead of this bizarre old market we seem to have let build up of just spending all this money far away from home. So I think there's a massive opportunity there. And the final thing I would say before opening or bringing in our panel speakers is, we at NHS England, and I announced this yesterday at the NHS England board in Norwich, are going to ask, or have asked, each of the ICBs for their 3-year plan to localise care and end out of area placements. They're not going to do that. You're not going to do that unless you're talking to partners like the ones we've heard and making plans with them, and the health trust leaning into that. And we have made a tiny amount of money available, well, 40 million, not tiny, but by the time you divide that by 42 ICBs, to help enable and facilitate that project and programme planning to make that move happen. So I'm just going to put that out there into the universe before bringing in Sarah Pearson, Neil Reveley and Jeremy Porteous. And I think, yeah, it would be really great if each of you could give a few reflections on the questions, the provocations and the stimulation of everything we've heard thus far. So can I bring Sarah in first, please?
Yes, of course. Good morning, everybody, and thanks very much. Wow, such a lot to go at there. You question about what can housing partners offer an ICS. I think the obvious is expertise, and I say that because the situation as it is in many places where there aren't housing teams going in, clinicians are having to make decisions about housing. And clearly that's not right. We wouldn't ask housing to do it the other way around. So that's one thing. Another thing that housing partners can offer the ICS is data. The amount of data that housing associations, housing providers collect on their residents is, you know, really extensive, you know, and that can help the ICS, the ICBs to assess need, strategic oversight planning. So there's that side of it. They can provide capital. The thing about that though is that, you know, we're looking at needing probably longer term contracts in order for this to be attractive and doable really for housing providers, with uplifts as well to mitigate sort of the internal risks on that. So although it can happen, it's something that has to be worked closely at. And of course, as we've heard, the hospital in-reach teams coming into the wards to assess that movement back out into the community. From the point of view of what the practical thing that the ICS can do, the best thing that the ICS can do is develop that ICS-owned mental health and housing strategy, for that to address all of the key interfaces between housing, inpatient care and the community. And that's certainly something that we do a lot of with HACT, is sort of bringing together those sort of different sectors. And we worked with Sussex Healthcare actually to develop the first mental health and housing strategy down there. So that's my thoughts on that. And yeah, absolutely, being sort of hearing about you know, the sort of plans that you're on about, the 3 to 5 year plans, and that started cropping up in conversations that we're having now. And there's a lot that can be done around that, but let my other panel members, you know, sort of comment on the main 2 points. Don't want to hog all the time.
Thank you. Can I bring Neil in then, please, for your thoughts on the get and the give, and who you are and what you do?
Okay, yeah, thank you. Good morning. I think it is just still morning, isn't it? So we can get away with good morning. So yeah, I'm Neil Reevely, and I have a sort of a dual role, if you like. My role is with something called Partners in Care and Health. Partners in Care and Health is a partnership between the LGA, the Local Government Association, and ADAS, the Association of Directors of Adult Social Services, and we deliver a programme on behalf of the Department of Health and Social Care, which many people, certainly who touch in local government, will be aware is around sector-led improvement. So it's really about how we take some of the great examples that we see around the country and how we share them and encourage innovation and improvement everywhere. And we also face in the other direction around policy development, supporting policy development, giving advice to DHSC, DLUC, or influencing, hopefully, in that regard. And in that sector-led improvement space, I'm sure Jeremy will talk a bit about that as well, because the Housing LIN is a fantastic, as people will know, a fantastic organisation in helping to share that information, and we often partner with the Housing LIN. So just linking to the sort of the questions that were put to us initially to start the discussion, if you like. So the practical thing the ICS can do to strengthen the role of housing in supporting mental health outcomes. I think some of what the ICS could do will support the interface of housing into health generally, as well as in mental health. Mental health clearly is one key aspect of it, but it will straddle into all aspects. And some of it, I think people have mentioned to some degree already, and has been in the questions, which is about it can increase its knowledge. So quite often we find ICB members, board members, ICS board members don't feel they have a great knowledge of housing, and we think there probably needs to be some sort of leadership within ICSs and ICB. So a housing lead, hopefully that might be a housing person who would be on the board or as part of the partnership, but if not, a senior leader within there who would take the lead to if you like, broker that bridge in housing. And then invite presentations to the board so that they get much more knowledge around what housing can do and how that can work. And hopefully, one of the things we often talk about, many of us were involved a number of years ago in setting up a national memorandum of understanding across health, housing and care. And we work with people to try and encourage, in effect, a local version of that across the ICS area to get that development of that partnership approach, because it will need that partnership approach to those solutions. You know, we've already talked about some great examples. Certainly I'm aware from the Wakefield example, a lady called Sarah Roxby, who's not on the call today, but linked to Wakefield, works into the ICS and the ICB to be the housing lead on a part-time basis, if you like, inside of that. And you see housing on the inside track of all of the stuff that happens in the West Yorkshire health partnership. So it pays those dividends. We're trying to do something similar across the North East region. In the North East, the ICS is the whole of the region and a little bit North East and North Cumbria. So we're trying to get that similar level partnership working. We're at the early stages, but we're trying to get that across the ICS. So I think leadership from the ICS, building up its knowledge, building up its expertise, and that will support, hopefully, the NHS and the ICB really getting behind contributing to that housing needs analysis, which local authorities will require, certainly housing authorities will require, to develop what will be required in the new Supported Housing Act of a 5-year rolling strategic approach to supported housing, and how we would do that. But it clearly needs to be influenced by the commissioning activity of the ICB more generally, as lots of people have put in the chat sometimes about resources. We can provide the bricks and mortar, we can work with housing partners, but that will only work if the right health infrastructure is in place, whether that's outreach services through an organisation like Home Group or directly through the NHS, in terms of that support network into communities to support people in the housing that they're in. In terms of what housing partners can offer to the ICS, I think Rachel touched on it really. Unfortunately, it would be lovely if the NHS were approaching housing organisations on a regular basis, but it doesn't happen. So I think what we're finding is innovative housing organisations need to approach their health colleagues and demonstrate what can be achieved and what offer they can put there and provide those practical solutions. I think the other thing we need from collective housing providers is sort of them willing to work in partnership as well. And I know from working with housing colleagues that they are, but quite often the NHS will say, well, we don't know who to engage in housing. If you take the North East as an example, 12 or 13 local authorities, so that's 12 strategic housing authorities who will set the housing policy, the housing strategies linked to planning, and I'm not sure how many housing providers, but many, quite a lot. So how do we talk to housing with the NHS, might say? We're trying to broker that in the North East through organisations, certainly in other parts of the country, through people like the National Housing Federation, and in the North East through the Northern Housing Consortium, who have housing as members. But how can we make it easy, if you like, for health to talk to housing as a collective? And the answer that was provided when we touched upon that question earlier about if we've got a housing organisation on the ward, is that housing organisation acting on behalf of all of housing providers or just that particular housing association? And perhaps we can use the sort of trusted assessor type model that is quite often used in all the people services around providers having a trusted assessor on the ward to direct people to the right place. Might that work with ICSs? That could be both an offer from housing organisations, but an ask of the NHS and ICBs to say, actually, if you were to do that, we could get that much more rounded collective service in all hospitals, particularly mental health wards. And how could you help fund that? So the joint funding arrangement, people have touched on the funding. Many housing is part of the BCF these days, the Better Care Fund, where high impact change models talk about the impact of housing. How can we partner up to provide that infrastructure in hospitals that would provide that route out, that flow, that pathway that you were talking about? Sorry, a bit long-winded, but that's my initial thoughts anyway.
That's brilliant, thank you, Neil. And I've been busily scribbling as you've all been speaking, and sort of I'm just struck by the deeply practical asks and offers that are being made. We'll come back to it, but next we'd really like to hear from Jeremy, please.
Oh, thanks, Claire. And I'm going to echo a little bit what Neil says. And for those of you who don't know me, I'm formerly the housing change agent in the Department of Health, and a rare beast who works across housing and health at a national level. But I echo what Neil was saying around the leadership piece on the one level. And the MOU that he refers to is a really important document. Now, unfortunately, it's only been taken on by a dozen or so authorities across England, but it does provide a really great footprint for the ICBs to work on and to build those effective partnerships within their local economies and to set priorities that are both in terms of investment, but also investment into new build, but also how to maintain existing services as well. And I've put the link to the MOU in the chat box. The link also for housing and its relevance is indeed about that data and having the analytics to understand what is the demand and the supply issues in those localities, and works both in the northeast but also in Greater Manchester demonstrate that there's actually an underrepresentation of need, and that has a big impact both in terms of the existing quality of accommodation, not just in the social housing sector that we've talked about today, but indeed many people placed into the private rented sector as well. So we need to think about how to ensure the continuity of care that can be accessed through services in that private sector, and that's where that Supported Housing Regulatory Oversight Act that Neil referred to is really important, because that will be one of the levers to understand what the demands are in those localities, and then how to look at the different investment levers to think about the reprovisioning, the transformation and the supply of a broad range of both supported housing, as well as many people with mental issues, with mental well-being issues living in ordinary mainstream housing as well. The other side of it is I chaired for a long time the Vulnerable and Older People's Group on the Homes England Advisory Group, which, and for many of you will know, that's the investment arm. And about 90% of the funding going into supported housing is actually for older people services and new build. Mental health and learning disability services is something which we really need to grow. And a bit like building your own home and building the right support that the learning disability movement have taken on subsequent to the Valuing People agenda, we really need an equivalent for mental health. And NHS England, I think, provides a really good approach for this. They already have a strategic commissioners network that Neil and I are on for LD services. We need to see how we can grow and branch that, because there's a significant workforce issue to share the learning and the good practice. And I just wanted to conclude on a couple of areas of good practice, and these people may already be on the call, and I just want to give a shout out to John Pritchard and Megan Ward, work that they're doing in Hampshire across Southern Health Trust and the New Forest area, where they're looking at homelessness prevention. They're providing routes into access into housing. They're also looking at preventative measures to reduce opportunities for step-up facilities to reduce some of the demand in more acute services. And then work that Rethink and Look Ahead and others have done to demonstrate the cost benefit of good quality housing. Now, finally, my final point is around the quality of that housing includes the design. And I think Marsha and a couple of others asked about aids and adaptations, and Neil's partly answered that in terms of Better Care Fund. But we also need to make sure that the quality of our build, both in terms of maintenance of it, but also going forward, has built into it mental well-being. So things around designing for a healthy life and the codes that DLUC and others are working towards at the moment are really important, because this will look at improved lighting, ventilation, issues around use of green and outdoor space to maintain issues around mental well-being. And that's very much a design issue about how we can make sure that our buildings are built and future-proofed as well for all.
Wow, there is just so much in there, and again, all of you very, very practical, very knowledgeable. You've got experience. It can work. It does work in many places. We need to make it work everywhere. I'm struck that I'm delighted actually that the ICS development programme that we're running at NHS England is alighting on absolutely essential topics for ICSs and ICBs to think about. And this is the 4th such development session. So housing and mental health right up there. I'd have liked us to be number 1, obviously, but I do understand that ICB and ICS colleagues have got a huge amount to think of. And I think it's great that we've got mental health up there today. Just a few thoughts. I mean, I've been very much scribbling lists, and obviously we've very much framed our questions about housing providers and what they can offer, and ICSs and ICBs and what they can offer. Jeremy, you touched on what you thought NHS England could help with as a whole, and one of the things that you mentioned was, do we need to, in mental health, have a strategic commissioning network? and I'm wondering if you can say a little bit more about how that works. And I'm wondering as well, and I'd love to hear in the chat from ICB colleagues, but also panel members, you've suggested some things the ICBs could do, like have a mental health and housing policy. I'd love to hear, should we mandate that, or will everybody go, oh, that's NHS England mandating stuff, we don't want to do it, therefore? Or would it, are there some things that we could mandate and build into this 3-year plan to bring people back from out of area locally, which will be hugely dependent on housing? Are there some things we should just say, no, these 2 or 3 things absolutely need to exist in the health landscape to facilitate this? But I don't know, Jeremy, if you want to start there, what more could NHS England do? But I'd love to hear from others.
Well, I must give credit to Neil, because I think he co-chairs the strategic commissioning group now. But it's very much built on the, as I said, the sort of building the right home and building the right support documents, and enabling NHS England to really understand, both at an acute level, issues around move-on accommodation and trying to free up those pathways that we've been talking about here in terms of mental health, but also experienced by many people who both may have mental health issues, but also a learning disability as well. People with autistic people as well. So again, there is an existing network that has built in through NHS and providers to further understand those issues, but also help NHS England to support their implementation of both their strategy, but also the capital money that it has available for reprovisioning of services back into the home. And what's quite neat about that is that money can also be match funded with Homes England, the GLA and other money at times, although there are technically some issues around the use of that money. But again, there are, it's a real good network. And what this does is not just look at around the policy direction, but shares examples of practice, looks at professional development, and really gets an opportunity to look at further research and development that may be needed as well.
Perhaps I could just come in on your question about should it be mandated. I think the NHS colleagues on the call will have to perhaps excuse me when I say it might be helpful, because as we know, the NHS quite often operates in a very sort of command and control type way of working, and it would be lovely if ICBs and others wanted to do this of their own volition, but unfortunately they've got lots of pressures on them, they've got lots of requirements on them, and sometimes it might be helpful. So I think Ewan mentioned right at the beginning, we were very pleased that the Adult Social Care White Paper talked about housing very strongly, and on the back of that we had expected a £300 million Housing Transformation Fund that suddenly disappeared. But nevertheless, the policy remains. The Department of Health and Social Care are being very clear that the policy direction in that white paper remains. That particular fund may not be there to help progress it, but nevertheless that remains. On the back of that, we did ask that DHSC make sure that ICBs, because they were being formed at about the time that that white paper was being published, that ICBs should have a statutory responsibility to engage with housing. And indeed, that statutory responsibility is there. But of course, ICBs have many statutory responsibilities, probably hundreds of statutory responsibilities. So getting people to focus on that one is a little bit more difficult. We then also managed to get this in the integration white paper that was published but unfortunately then withdrawn. So if the integration white paper the government published had continued, then the requirement to engage housing into health was also in that integration white paper. So I think any sort of leverage, if you like, that we can use to help those ICBs who haven't seen the light of housing, if you see what I mean, those who aren't engaged in this process. So I think we need to tackle it from both ends. Any encouragement formally through NHS England would be helpful, but I think that needs to be replicated by all the good practice stuff that we've been describing. So the bottom up as well as the top down, in terms of describing and pointing to some of the really good examples that we can see. Certainly I've used the West Yorkshire one on many occasions because, and Sarah and others have helpfully presented that to other ICBs, which have sort of shown that. I think what needs to follow from that clearly is commissioning and funding. A couple of people in the chat earlier in the session talked about, it's the elephant in the room. You know, where's the money coming from? It's already, you know, and how do we manage that? Well, we can't keep passing the parcel. You know, but we can't say, well, we want housing to do this, therefore housing have to find all the money, or social care have to find all the money. Everyone's got some resource issues, if you like, but actually, if we had that combination, that partnership approach, and using those joint funding initiatives, if needs be, demonstrating that efficiency, certainly for health and social care and others, in how these systems work. And the National Housing Federation, I think, had some background information in the past that absolutely demonstrates the efficiency that can be provided by these housing-based solutions. But we then need a joint approach to the funding. And while everybody's cash strapped, not least the NHS, of course, but the NHS probably has some of the greater flexibility, if you like, in that funding to see these outcomes achieved.
Yeah, can I come in there?
Yes,
Claire?
please do. I was going to ask you.
Yeah, I'm just going to be really sort of straight to put in my answer when you ask about, you know, should it be mandated? Absolutely, yes. And the reason that I feel that way is because of having seen the sort of impact that having a mental health and housing strategy can have, and how quickly it can have that impact. And by the way, I'm very conscious I was so keen to speak earlier, I didn't actually say that, yeah, I'm health and research at HAC, the Housing Association's Charitable Trust, and we do work in sort of driving innovation and collaboration with the housing sector, social housing sector, and NHS, local authorities, etc. And yeah, I mean, I've already mentioned the work that we've done at Sussex with the first housing strategy there, and, you know, sort of pulling the strategy together, developing pathways, the multi-agency working group, place-based plans, very sort of practical sort of stuff. But then part of that strategy was bringing aboard an associate director for housing, and we helped then in developing a business case for the housing team. So it's actually, you know, the trust that provides the housing team, for example, in Sussex, and they're place-based. So each local authority has their own housing member, and you know, for the reason I say it's the results, when you're looking at the impact that's happened in Sussex in 12 months of the housing team being in place. We know that delayed transfers of care, largely due to housing barriers and issues, and in the last 12 months, the detox due to housing issues have reduced by 50% in 12 months, and it's expected that by year 2 then that's going to be down to 0, and that is a really quick impact that's made. And when we talk about the NHS being cash strapped, and also, Claire, like yourself, last year saw my 40 years working in health starting as a nurse, so I know that feeling. It seems that 5 minutes since me and Florence Nightingale started working together, but yeah, the NHS spends so much time dealing with, you know, the firefighting and what have you, and at one point it has to say, no, hang on a minute, we've got to start thinking forward, you know, strategizing for this, and this is a really straightforward way of doing that. Absolutely.
Could I thank you for that? Could I ask you to say a bit more about capital? Because if you speak to anyone in the NHS about capital, we wail and gnash our teeth and wring our hands, because we really don't have enough. And right across the country there are examples of operating theatres being closed, you know, just the operation grinding to a halt or being compromised because of capital. And yet a couple of you have mentioned you have capital or access to capital, and could any of the three of you say a bit more about, is that real? How do we unlock it?
Shall I start, and perhaps then others? Yeah, because I used to manage the actual Department of Health Capital Programme. So it was then called the Extra Care Housing Fund. It's now called the Care and Support Specialised Housing Fund. It is traditionally a 3-year programme. It's administered by Homes England and the Mayor of London's office, the GLA, for the councils in London. And there is a bidding rounds that are made on an annual basis to enable housing associations with their partner and their partners, both in the voluntary and third sector, but also statutory partners as well, to explore opportunities to build new, or indeed in some cases convert or renovate existing accommodation. There's also other capital funding streams administered through public sector housing grants through their Affordable Homes Programme or the Housing Programme. And as I said earlier, about 10% of that money is set aside for supported living. And supported housing, including housing for older adults. So there are avenues. There is other monies that's available through local government. There's also big issues around planning, building regulations. There's a whole supply chain issue as well for both new build and renovation or remodelling existing stock. And for other people, that Neil touched on the Better Care Fund, who need to adapt their existing homes through things like disabled facilities grants, again through local authorities and in some cases with their Better Care Fund partners, to adapt to make improvements to existing stock as well for personal modifications. So there's sort of both structural funding as well as individualised funding down to a property level.
That's so interesting. Neil or Sarah, would you like to say anything more about that? That was a pretty comprehensive answer.
Yeah, I think a couple of things. I think Rachel touched upon it in her answers to a question earlier, in that for many housing associations, properties already exist, so they don't necessarily need new capital. They either convert existing stock to this particular purpose, or certainly in the case of many people who need to be discharged in relation to their mental health issues, quite often we don't need such bespoke housing. You know, quite often with people with very complex needs, we have both learning disability and or autism or specific older people's properties, they need to be, you know, specially adapted or whatever. For a lot of people in the mental health world, quite often that isn't the case. It's about the support services that they need to live in that property. So quite often mainstream properties are suitable for lots of people who are in need of housing as part of their mental health pathway. And in that regard, housing associations are developing houses every day of the week. You know, so houses are being developed. That partnership potentially can allocate some of those properties, you know, for particular people or for particular ways of working. Where capital is required, the Affordable Homes Programme is how housing associations get access to that capital, and as I've said, they're doing that all of the time and developing new homes. When stuff needs to be a bit more bespoke, then yes, sometimes additional capital is needed, and either the cash fund that Jeremy's referenced, or quite often Homes England will give additional grant rates in that area, or as I said before, housing associations can repurpose existing properties. So I think whilst capital, I know, is an issue quite often in the health service, in this space, I would say don't get too wrapped up about capital. The housing associations will probably be able to manage that part of it. What housing associations require is the commitment of their health and social care colleagues, that if they commit properties in this way and they got and you know, the housing association gets 40-year funding to deliver this property, actually the support services are going to be there to support the people who live in them. It's that ongoing revenue support that is the risk factor potentially for housing associations, yeah, much less so the capital.
Yeah, good point.
Thank you for that. I don't know, Sarah, whether you wanted to say anything on that point in particular, or has it been said? You're on mute.
Apologies, I was just going to say I think that Jeremy and Neil have more or less covered that off. To be honest, I don't think I've got anything additional to add to what they've said.
Thank you. I'd like to come back to questions that are coming through quite a bit at the moment, and I'd like to comment myself and then ask our panel if there's anything they would like to add. So one of this thing of money, right, it really does matter, and we all need and want more. But at the minute we've got what we've got, and moving it to the right place and being creative with what we've got is important. So quite a few questions saying, well, how do we get money out of the acute hospital sector? and into the community. Now, just a few facts. At the minute, acute beds in mental health are running at between 96 and 100% bed occupancy. Royal College of Psychs and others would say you can't run an acute responsive inpatient service at anything much above 85% bed occupancy. When our acute colleagues in the general hospitals reach 92% occupancy, all sorts of alarm bells go off. So our length of stay is creeping up. It was 34 days before COVID, it's now at 54 days, and I guarantee you that most of that increase isn't because of the person's need, it's because of these blocks. And I made the point at the beginning, I think it's unethical to detain people in hospital longer because we as systems haven't got our act together to enable them to leave. There are many calls to open more acute inpatient beds. You'll see it in the newspaper every other day. There are people who believe passionately that the answer is more acute beds. Look, in some parts of the country it might just be that they're really underbedded, but all of our national work shows us there isn't a formula that says you need this many beds per head of the population. And the reason that formula doesn't exist is because what our learning has told us is the stronger the partnership and the community infrastructure around housing and outreach support, the fewer the beds you need. So, and it makes sense. So it does seem to me that it's going to be very difficult to reduce the numbers of acute beds we currently have. Generally, I mean, we've got a quarter of the beds we had 25 years ago. We've lost 75% of them. I don't think any other sector of health has done that, so bravo. And I have to remember housing associations being there in those early days when the large asylums were closing, and I was a ward sister and I cried because for the first time I saw people thrilled that they were choosing duvets and duvet covers, and all they'd had was a hospital blanket all those years. So this has been a long journey and our housing provider's been amazing, but I cannot emphasize enough to both our housing colleagues and to the ICSs, the wider systems, that we, the health service, spend hundreds of millions of pounds out of area in the acute space, in the rehab space, in pretty often quite unregulated, far from home, out of sight, out of mind kind placements, many of them the lot rehab ones, not even evidence-based in what they do. And it seems to me there is gold in their hills. There's financial gold, but there's human opportunity and gold. So I think there's loads of opportunity here. Anyway, I just wanted the panel to comment on that, and then I'm really aware that I'm going to sort of take 1 minute and then hand over to Ewan for the last word.
Yeah, I'd just like to come in on the out of area placements and what have you, Claire. Absolutely, it's something that we have a lot of conversations at HAT with health partners around this. As you say, locked rehab, out of area, and the amount spent is absolutely ridiculous. And the only way to tackle this is just to come together in the ways previously stated. And there has to be that sort of, as you say, that cross-sector coming together, that multi-agency working, and very much about getting down into the nitty-gritty of, you know, what are your knowing what's available to you, what housing, what accommodation is out there in the area. And the only way you can do that is by digging deep down into the figures or getting somebody to do that for you, really looking at your lengths of stays and your delayed transfers of care. And then the important bit is then brokering that relationship with housing providers. So whilst it might seem okay, it's a bit of a cost exercise to pull all of this together, when you look then at the money that you're going to save by putting people into local housing, local accommodation, rather than out of area lot rehab, it's ridiculous numbers. You're quite right. So it's a bit of a no-brainer, really.
Neil, Jeremy, last words from you, please.
Yeah.
Thank you for that, Sarah.
I just think, taking your ask about how do we move money from acute, I think sadly the evidence is there. It's just getting people to do it in some way. So it's firstly about the knowledge, of what's required, the evidence, and I think Sarah gave us some fantastic evidence of, 50% reduction in delayed transfers in 2 years, and zero, or sorry, in the first year, and zero after 2 years. So systems get the evidence. We then need the leadership to take that evidence and say, okay, we've got the evidence, we're now going to do this. And if they're not doing it, it returns to your point, well, do NHS England mandate them to do so?
Thank you very much, Neil.
For three things I'd like to leave you with is, one is we need to be much more innovative around the types of housing supply we have. One of the dangers, if we're just thinking rehab, is that the next step will be thinking, actually, if we can't move and enable people to move, to step down, the only other option is residential care, and we want to avoid that as well. So again, we need to look at the whole accommodation economy, and for me the first step is to have a place-based approach, and something like the MOU can help reinforce that. The other things around where technology might play a little bit of a help, both in terms of personal care and support, but also the way that health and housing can integrate much more effectively through case management, through communications, etc. And lastly, perhaps coming back to where Ewan kicked off this morning around the work of shared lives, I think social prescribing has a lot to play here as well. And some of the work that Hacked and ourselves have done together around work with Bromford, for example, around look at neighbourhood coaching, where it's not a landlord-tenant relationship. It's about enabling the residents to better understand their experiences and how to resolve their own issues with support as and when they choose.
I love this. So look, I've heard really about knowledge, evidence, leadership and action, I think, Neil, from you. I've heard ICS, you need a housing and mental health strategy, a housing lead. You need the knowledge within the organisation. You need to be actively reaching out and making your contact points and how to communicate with you easier. And I've heard long-term commitments and partnerships so that you can allow partners to innovate. I've certainly heard from housing partners that you've got all sorts of things to offer, and you're reflecting on, could you do even more assertive in-reach to health, and what might we do to help you do that. Could you organise yourselves in ways where you have a trusted assessor operating for the whole market and possibility if health opens its doors more? So something you're thinking about, lots of data you're offering. NHSE, we need to think about policy support. We're putting that 40 million out this year. Do we mandate some of that for a mental health and housing policy and a leader? I don't know. I'd love to hear from people. And I'm going to hand over for the final word to Ewan and this lovely shared lives concept, which I just adore.
Thank you very much. Well, look, I think everyone has made the right kind of points at the end. I just think maybe one image that stuck with me from today is Sean and how his life has been transformed, and that's only through social care, health, housing, voluntary sector, the NHS working together to improve outcomes for that individual. And we should see many more Seans emerge over the next few years if we all work together. I'm just going to thank the speakers for your contributions. Really good. Thank you, everyone. I think we're out of time, so I'll probably just say have a good rest of the day and a happy restful weekend. Thank you very much.
Thank you so much, everyone. I hope you all feel time well spent. I want to name it a Dogs for All policy, being a dog lover. I love that Sean got a dog. But thank you, everyone.
Thanks,
have a good weekend when you get to it.
Bye.
Bye, everyone.
Bye.